Dr. Tan is a consultant at the Department of Hematology at Singapore General Hospital. His main interest lies in the area of hemostasis and thrombosis and platelet disorders. His works cover both the clinical and laboratory services in this field. He has received several competitive research grants and has published extensively. He is active in teaching and speaks in workshops and seminars on topics pertaining to hemostasis and thrombosis. He is currently an adjunct associate professor for Duke NUS, a clinical lecturer for the Yong Loo Lin School of Medicine, National University of Singapore, and as well as the hematology lead for Lee Kung Chian Medical School. Dr. Tan, please.
Hi everyone, I'm Chen Wen, a consultant hematologist from Singapore General Hospital. First of all, I'd like to thank the organizing committee for inviting me to present on this topic of thrombotic complications in COVID-19 patients. So let's quickly look at the timeline of the development of COVID-19 in specific relation to the thrombotic complications. So COVID-19 was first reported in China in December 2019, and it spread rapidly across the globe and was declared a pandemic by March 2020. So within 2 months of pandemic declaration, even the mainstream media had started reporting the presence of thrombotic complications developing in COVID-19 patients. All these news headlines highlighted the disease burden of thrombotic complications and the interests of the public and those in the healthcare and scientific fields have in that. So that leads to the presentation topic today. I hope to cover the pathophysiology of hypercoagulability in COVID-19 briefly, and then to explore the clinical evidence available in terms of epidemiological and clinical data, and the management of prothrombotic state in COVID-19. I'll also share some personal perspective by incorporating some of our local data and experience as applicable. Let's start by looking into the pathophysiology. This is a rather busy and complicated diagram, but this only partly encapsulates the complex interactions between immune response of infection and coagulation pathway contributing to hypercoagulable state in COVID-19. This crosstalk, I must say, is not unique to COVID-19 actually, and it happens even in other viral infections, including influenza. However, at least some of the reactions are accentuated in COVID-19, and the exact reasons of this exaggerated response are not completely apparent at this moment. What we do know is in severe COVID-19, many pro-inflammatory cytokines are generated, and these cytokines stimulate endothelial cell and other circulating white blood cell and platelets in the circulation. And this causes further activation of the coagulation pathway. Following that, all the coagulation proteases generated can bind to and activate specific inflammatory cells and cause a heightened inflammatory response. And subsequently, this heightened inflammatory response can in turn provide feedback to the coagulation system, triggering a continuous feedback loop of immune and coagulation system activation. In addition, natural anticoagulant and fibrinolytic pathways are also affected in COVID-19. As you could see, there is not a single or simple mechanism to account for the prothrombotic state in severe COVID-19. Much remains unknown in all of this complex intersection and interactions of various coagulation and inflammatory and immune pathways. Early on in the timeline of COVID-19 pandemic, thrombotic complications have been noticed. The Chinese were probably the first group to observe this association. They actually conducted a prospective study during the height of the outbreak in Wuhan. They performed Doppler ultrasound of all the COVID-19 patients admitted to a few of their wards and showed that a surprisingly high 46% of the patients actually had lower limb DVT. Of this, about 1/3 of the DVTs were above knee, and about 1/5 of these cases are actually symptomatic. Our group in Singapore was also among the first to recognize the connection between severe COVID-19 and prothrombotic state. By using coagulation assays, we demonstrated that patients with severe COVID-19 were hypercoagulable. And very soon after COVID-19 spread to Europe, the Dutch group reported remarkably high rate of thrombotic events among the COVID-19 patients in ICU. Around 30% of their patients actually developed thrombosis, of which majority of these events were venous in nature. Interestingly, around the same time, based on the Singapore National Audit data, we only saw 2 and 10% of our ICU patients developing venous and arterial events respectively. These thrombotic rates were pointedly different from what was published then. And believe me when I say that it's really difficult to convince journal reviewers and editors then to accept divergent data. However, subsequent data from larger epidemiological series in the States mainly show a slightly different picture, one that is closer to what we observed back in Singapore. One of these reports is based on data from more than 6,000 COVID-19 patients. VTE was reported in only about 7% of the ICU patients, whereas majority of the general ward cases are actually reported very low thrombotic rates of less than 3%. Another series from New York included more than 3,000 patients and reported arterial event rate of about 10%, and VTE was reported to be only about 13% of the ICU patients and 4% of the non-ICU patients. As mentioned earlier, the association between thrombosis and viral infection is not unique to COVID. Other viral infections have been reported to be prothrombotic as well. Hence, in Singapore, we compared the thrombogenicity of COVID-19 versus other non-COVID-19 viral infections. So we had about 170 patients in each arm, and we demonstrated no significant difference in thrombotic events between the two groups, although I must say the sample size is relatively small. These differing VTE rates reported, we believe, could arise from a few reasons. Firstly, early detection and hospital presentation of COVID-19 cases play a role. In settings where healthcare resources aren't stretched, the thrombotic rates appear lower. Improved medical care and awareness of thrombotic association in COVID-19 could be key as well. Lastly, different reports included patients of differing demographics as their study populations. For example, cases in Singapore comprise of mainly younger adults with fewer comorbidities compared to the rest, and hence we saw fewer thrombotic events. These differences highlight the importance of continuous assessment of emerging data as the pandemic evolves and the need for local data and the significance of understanding and interpreting them. The thrombotic risk in COVID-19 is also dynamic. The hypercoagulability increases with the severity of infection, as shown earlier as well, with the risk highest among ICU patients, and probably the risk goes down as the patient become less ill or in ambulatory setting. Also, the thrombotic risk appears to return to baseline at convalescence phase of COVID-19. So, using this global hemostatic assay called clot waveform analysis, our group showed that the dynamic changes of prothrombotic risk in COVID-19. So, as you could see, as the disease gets worse, as patient entering ICU stage, as shown as these gray boxes, all this coagulation assay went up. And as the disease improves, it actually comes down. And towards convalescence, they actually come back to a baseline normal range. So this data also is supported by clinical events as well. So we actually follow some of our COVID-19 patients longitudinally, and their clinical thrombotic rate was actually very low after disease convalescence. With regards to management, these are the three main areas that I'll be focusing on. Coagulation assays such as D-dimer have been shown to be markedly abnormal in COVID-19 cases, especially in the more severe infection. And these are associated with poorer clinical outcome and death. However, at this present moment, the role of this assay remains for prognostication purpose, and medical intervention should not be initiated or changed based on these abnormal lab findings alone. And once the thrombosis is confirmed, its management is the same as for those without COVID-19. However, the best way to prevent development of thrombosis in COVID-19 is an area of controversy and of active research at this moment. These are some of the published recommendations on thromboprophylaxis in COVID-19. These are taken from some of the key professional bodies, for example, the WHO, NIH, and CHEST. All of them recognize the increased thrombotic risk in hospitalized COVID-19 patients, especially those ill ones. Most would recommend prophylactic dose of anticoagulants in critically ill COVID-19 patients in the absence of contraindication. However, recommendation of higher doses of prophylactic anticoagulant use, the best duration of prophylaxis, and prophylaxis in less ill and ambulatory patients remain vague, and sometimes some of the recommendations contradict each other. All this highlight the need for more and better evidence and data in this area. This is preprint results combining data from 3 randomized controlled trials, REMAP-CAP, ACTIV-4A, and ATTACK. These multinational studies aim to evaluate the therapeutic anticoagulation use could lead to a better clinical outcome than standard pharmacological thromboprophylaxis in COVID-19 patients. These are the data in just the critically ill group. While there were fewer major thrombotic events in the therapeutic anticoagulation arm, the number of deaths is actually comparable. And there is also a slight trend of higher risk of bleeding for those who receive full therapeutic dose of anticoagulation as a form of thromboprophylaxis. So based on this, the conclusion was higher dose of anticoagulant might not be useful and can potentially cause harm. And this has actually resulted in the halting of further enrollment of patients into the critically ill COVID arm of these 3 main studies. Hence, regarding thromboprophylaxis in COVID-19, we are still back to the standard of care of thromboprophylaxis practice at this moment, at least for those critically ill patients. The ongoing studies will evaluate for the less ill patients whether there is a role of giving higher dose and whether there's a role to extend the duration of anticoagulation upon discharge as well. So these are some of my personal recommendations. I would prefer individualized management of the patient by carefully assessing the underlying thrombotic and bleeding risk factors. And at this moment, there is little evidence to support the use of thromboprophylaxis for ambulatory COVID-19 patients. So in summary, patients with COVID-19, especially severe COVID-19, are at higher risk of thrombosis, and its underlying pathophysiology is likely complex and multifactorial. Reducing this risk with thromboprophylaxis involves careful evaluation of clinical risks and benefits. And there are still many unanswered questions, and I'm certain more exciting developments and data will be made available in the near future. On this note, I would like to end my presentation and thank you very much for your attention.
Good afternoon, Dr. Tan. Hello, welcome to ACCP.
Yeah.
Hi.